So good morning. It's really a privilege to be here for several reasons. First, I'm with friends. And second, in some way, I'm touching a subject that I would say that seems to be, again, a classical one, but clearly we may look to this discussion about the off periods in a different way. So I hope that our discussion in some way favors that rediscovery of the off period. So my task is a little bit to, discuss if we have different types of offs, and in some way if there is any problem with the classical clinical, type of definition we are applying today. Those are my disclosures. Again, it's interesting because, again, when I was proposed to touch this topic, I felt a little, a little surprised. Why discussing something that it's so obvious and so simple, I would say, at least in clinical terms. And this week I was discussing the results of, again, clinical trials in the, clinical trials targeting wearing off, so targeting motor fluctuations. And I was saying that in general we tend to recruit patients with 1 hour and a half of off time as an inclusion criteria, and we end up including patients with 6-7 hours of off. And someone made the comment that it's strange. So clearly you are recruiting patients that are not optimally treated. But in fact, this is something that is transversal to almost all trials when we are, targeting wearing off using oral drugs. It's like if there was a dissociation between what we want to recruit in terms of the characteristics of the patients and exactly the type of patients we recruit. And probably there may be something with our classification of off that ends up with patients, choosing the off period regarding their own status during the day that, it's not in line with the perception from the physician. So clearly I think there is something that, deserves, at least a discussion. When we discuss off periods, we discuss clearly what we call the advanced stage of the disease. So it's what appears there in that graphic as the motor complications. And this is, I like very much this figure because it really demonstrates that PD, it's a very heterogeneous disease. And I will try to touch this off period, not just on this classical advanced stage period, but also, crossing all the stages of the disease. And I will start, with very simple, definitions, starting from what I may call the classical view regarding motor fluctuation. And the classical view is that we start by having what we call an honeymoon period. So whatever we do in terms of treatment, patients respond well. The patient is happy with the physician, the family are happy with the physicians, and we have a response that has a duration of 24 hours. We may even use, one pill of levodopa once a day, and we get an effect that it's really, long-term, and clearly it covers the 24 hours of the day. The problem is that after some time, we start having what we call wearing off, and wearing off is this end-of-dose deterioration or recurrence of Parkinsonian signs. And in general, it's someone that, has its first intake in 9 a.m. or 8 a.m. in the morning, and when it reaches 11 a.m., clearly feels that he's not as well as he was during the peak of the effect of that morning intake. So it's a classical view. We all know this phenomena. We call it wearing off. And it's clearly, what I would say as, again, the easy way and the way we teach this type of phenomena to our students. So wearing off, it's this early deterioration in terms of Parkinsonism. It starts by having a duration of, of effect of 4 to 6 hours. At the later stage, the duration tends to decrease. And as a sign of severity, those predictable deterioration moments become unpredictable. So it's what we call a sign of the progression in terms of severity of those motor fluctuations. So it's like a clinical marker of the severity of the disease. We use a different terminology. We use this terminology of on-off fluctuations, and that's what I wrote in this slide. It's a sudden, random, unpredictable loss of treatment effect. And again, this is like, we have patients that are slightly more severe than the ones that just have wearing off, and wearing off may just be, nocturnal akinesia or early morning akinesia. Again, if we continue thinking in terms of progression, in terms of having, again, a greater severity in terms of the disease, then we tend to find a different type of phenomena. That's what we call beginning of of those problems are those patients that get an effect, but not after 15 minutes or 20 minutes. They get an effect after half an hour, 45 minutes. That's what we call delayed on. And again, this is another term applied in terms of an extra severity of those motor complications. Even more severe, again, continuing on this severity trajectory, we have what we call a no-on phenomena, or again, using other words, a dose failure. So we have an intake 9 a.m. in the morning, again, and we reach the second intake of the day without getting any effect. So it's like if there was no effect for that specific intake, for that specific dose. So again, this is the classical view from the early onset wearing off to an on-off that is unpredictable to this beginning of those problems. Then again, we have a different type of perspective. This is what I call the forgotten motor fluctuations, because we tend to think in terms of motor fluctuations as a synonym of wearing off, so end of dose deterioration. So we tend to forget what it's the same thing, it's the same phenomena, but it's not after the intake of levodopa, it's not the end of dose deterioration, it's the time between the intake and the onset of the effect. That's what's its time to on. This is an old study from the Tel Aviv group, and clearly they recognize in this specific study that time to on, it's even more relevant in terms of duration compared with the wearing off phenomena. So it's not just forgotten, so we tend not to describe it in this way. It's also probably in terms of duration longer, so it clearly brings some additional relevancy. So what about the spectrum of the disease? When we refer to on-off fluctuations, when we refer to motor fluctuations, again, clearly we refer to what we call the advanced stage, what it's also a tricky name, advanced stage, because it's clearly associated with these motor phenomena. So no doubt that clearly that's what predominates in that clinical stage, and we see that even in that stage, the frequency of patients with motor complications increase with disease duration. But surprisingly, motor fluctuations and off, it's just not, it's not just something that it's exclusive of this disease staging. For instance, if we look, we find something. Again, the L-DOPA trial, again, it's very pedagogic in some terms. It's also pedagogic that after 9 months of treatment with levodopa at an early stage trial, 20% of the patients already had wearing off. This was something that I would say we could be surprised. So after 9 months, 20% of the patients, again, early stage, treated with levodopa with different doses, 20% had wearing off. So wearing off and off, it's not just something that we find at an advanced stage of the disease. We can also find, if we look attentively, also at an early stage. But also at the late stage. The characteristics of the off at the late stage, may be different, and they are different, and we can after discuss it. But it's still something that we find even in patients that we call as being the late stage patients. And late stage means patients that have lost autonomy, that are dependent. And again, those are just 3 studies with patients with more than 15 years of disease duration. And you see that wearing off is still there. The majority of the patients have wearing off. It's interesting that they also have dyskinesia. They have a different type of dyskinesia. They have less disabling dyskinesia. So the phenomena at the late stage, it's different, but wearing off, on-off fluctuation, it's still part of this late stage. Now we start discussing what the characteristics of that off. And clearly when we start, discussing the non-motor problems associated with PD, we also discover that also the non-motor problems fluctuate. And they are also frequent at all those disease stages that I have described, including late stage. And those non-motor problems means, neuropsychiatric, these autonomic sensory problems. So we have what I call the classical model. And the classical model of PD, it's the classical ONER, staging process. So we have, early stage, advanced stage, and now what we call late stage. And we have, the progression of the disease, covers the appearance of the levodopa-induced motor complications. This classical view really misses something, and it misses, the non-motor symptoms that I will touch again, and also, the axial signs, gait, posture instability, that really we know that there are major determinants of disability and loss of autonomy at later stages, but they tend to be forgotten in the classical staging that we are using. The other problem about motor fluctuation is that we tend to recruit patients for our motor fluctuation trials that have specific characteristics. Even if we are recruiting patients with 6 hours, 7 hours of off, we tend to exclude from those, oral pharmacological treatments patients with unpredictable on-off. So probably patients with more severe forms of motor fluctuations, we are excluding them intentionally from those trials. That's why when we produce this guideline table, these recommendations, we tend to have less information regarding those severe motor fluctuations. What I'm showing now, it's a classical patient, advanced stage. This is nothing for you again, attendees that have experience seeing patients, PD patient. This is a classical patient on off, and then he takes a pill, a miraculous pill, and is on. Why do I bring this video? Clearly, this video, this awakening effect, this amazing effect, it's motor related. So when we say that in the first part the patient is off, we are based on his motor state, and when we say that in the second part is on, again it's on his motor state. But I can describe that the patient was very depressed when he was off, based on this criteria, and completely euphoric when he was on. So in functional terms, I cannot tell you if he was better when he was off or on based on this motor state criteria. So in some way, that's what I would like to, to bring you for the discussion. Again, this is just one paper. There are several, and I know that Professor Stacy will also present you some additional data in line with the concept that I will share. And the concept is that in those patients that we call advanced stage PD, when we evaluate them on and off, we have also non-motor problems that also fluctuate. So you see in those, on the right part of the slide table, you see that in this study, this is a cross-sectional study, with 100 subjects, you see, many problems, non-motor problems, and you see that the frequency of the occurrence of those problems is different between off and on. Things like fatigue, humor, clearly it varies. This is also interesting because in some way this is a paradox. And the paradox is that we tend to say that, levodopa or dopamine agonists or anti-Parkinsonian drugs are just effective or efficacious for the treatment of mainly of motor problems, tremor, rigidity, and we tend to say that, the response, it's not so obvious for those other non-motor problems. But this is a paradox because what we see here is that when patients are off, they present more frequently, clearly disabling problems like pain, depression, anxiety. So I would like to alert you that in some way we tend, by using and by copying this type of classical views, we end up falling in our own concepts. This is just another way to look to the same phenomena. So in the previous slide, that I'm back, you see you have motor-defined on and off. And this is the classical view. And even using this classical view, you have this different response. Like if patients responded to those non-motor problems, there was a dopaminergic response even for those non-motor problems. But we can have what I may call cognitive defined off or behavioral defined off. And it would be interesting if there would be even a dissociation. So a cognitive defined off may be different from a motor defined off. And in some way you have there, very well-known phenomena like, humor, apathy, euphoria. Euphoria for, a behavioral can be found in a behavioral on, and apathy can be found in a behavioral off. So it's tricky, but clearly this is what I would like to alert you, and in some way for this, the classical view that it's a motor-defined on and off. Just some additional ideas. Clearly patients weighted the dopaminergic response of those different symptoms in different ways, and there are many, publications already that demonstrate that, and also demonstrate that the physician's perspective may be different from the patient's perspective. Clearly, we all know that the non-motor fluctuations are very heterogeneous, And clearly the psychic, non-motor symptoms fluctuate more frequently than others. And clearly they are one of the most troublesome, or I would say that more contribute to disability. And on the other hand, we also know that some of the non-motor fluctuations in terms of severity do not correlate with motor function. So we have a problem there. A good example is anxiety. Even if we tend to say that patients, when they are off, are more anxious, this is not always like that. And this is something that, again, a type of example where we have data that supports that there may be different types of response. So, in conclusion, again, our current definition of OFF, it's really based on severity of motor symptoms. And clearly, this is not just based on motor symptoms, it's a concept that it's based on a motor-defined off stage. So it's not defined on a cognitive or behavior or functional off stage. Clearly, it does not include non-motor symptoms, and we also know that the neuropsychiatric symptoms, and some of those I have already alerted you, are the most frequent and troublesome non-motor symptoms related with the off stage. And on the other hand, there may be a reason why this happens. It's because we tend to measure what it's easier to measure. And clearly, these type of phenomena are not easy to be measured, and this may be one of the reasons why we tend not to identify them or report them. So, trying to respond to the title, the question that was in the title of my presentation, that was, if there is a need for a redefinition of the OFF, I would say that at least it merits a discussion, and we may discuss if there is a need to redefine, or, again, as an alternative, to define a new operational way to define OFF. And this may be based on fluctuating functional or fluctuating health status states, and not on motor fluctuations. And we may even, end up by proposing that we should define also a troublesome OFF. And this is really interesting, because when we go back to the classical Hauser diary, to the classical motor fluctuation diary, why do we have, 3 columns for the on and just 1 column for the off? And this may be one of the reasons why we are recruiting patients with, more than 1 hour of off time, and we end up recruiting patients with 6 hours or 7 hours, at least based on the way, patients complete those diaries. So I would not exclude that at some point we would need also to redefine the off and have what I would call a non-troublesome off and a troublesome off. And the troublesome off may be the off that really it's in the mind of the physicians, that very severe off that, that runs with pain or some other phenomena that for the physicians really are troublesome. But the dissociation between the physician and the patient is something that we all know. And this may be also the reason why we tend to recruit patients with clearly a duration of the off that it's not in line with our own perception as physicians. And I stop here, and I would be happy to discuss this topic later. Thank you.
Joaquin, we have a panel discussion at the end, so I'll invite now Professor Stacy from US. He will tell us how measure of state, current limitation and future possibilities. Mark?
Thank you, and I'd like to thank the organizers for inviting me to this meeting in lovely city. I'm going to talk about scales for measuring wearing off, and tell you that I believe scales are very important in developing a standardization for how to measure and talk about patients at meetings. But the most important thing I can tell you is that OFF understanding is based on a doctor-patient relationship. And we all deal with these problems, and we're all able to recognize when the off periods occur and when they don't. I like the idea that Dr. Farad presented about a troublesome off. I like the term bothersome better, because there are many symptoms of off that I'll discuss that are okay with patients, just like dyskinesias are not bothersome at times, but there are times that they're really bothersome. And I think that that may be where we have room to improve. So here are my disclosures. I think most importantly, Duke University does own my IP and many others' IP for the wearing off questionnaire, and I'm going to talk about that as a measurement for wearing off. But I'm going to talk about defining an off period, identifying wearing off, how to measure the severity of wearing off, with the scales that we currently have, which are the UPDRS-3 to really look at motor function, the UPDRS-4 to look at whether you're having off periods or not, fluctuation diaries, and then this newer era of better mousetraps, as we say, for a device assessment of wearing off. So this was a paper that was published many years ago in which we were trying to really find a line to describe what wearing off looks like. And so if you look at that sinusoidal line, you take a dose of medication, you turn on, you might develop a peak dose symptoms, and the medicine, as it begins to leave your system, you begin to have return of your Parkinson's symptoms. And so we talked about this reemergence of off symptoms as a wearing off sort of problem. And this was a definition that we came up with in a later manuscript in which we tried to really formally describe wearing off. And like the UPDRS and like many other scales, we were trying to define wearing off in terms of our concepts of levodopa. So levodopa has informed most of our early scales, and trying to look at other medications in response to levodopa is not always an effective way to look at these medicines. So here's a closing of a window. So Dr. Ferreira talked about a honeymoon period and period when people do really well. With disease progression, your response to levodopa becomes more tight, and as you lose these neurons in Parkinson's disease, remember you only have 15% of your substantia nigra pathway when you begin to develop symptoms of Parkinson's disease. So let's say you get to 9 or 10%, then your window of response is really typical or predictive of where your levodopa levels are in the blood. And so here is a typical patient with off time and dyskinesias in response to medications. One of the things that we learned in that early trial of looking at wearing off, we had patients on PO forms of dopamine agonists, and we found that there were patients who had wearing off with those. And so this is not a profound statement at all, but if you take a long-acting compound, if you wait days after you take that long-acting compound, of course you're going to have wearing off. And so this is my depiction of you can have wearing off on a long-acting dopamine agonist, but you don't have dyskinesias, so you don't reach that point of dyskinesia with these drugs. So here's what I'm really supposed to talk about is the wearing off symptomatology and how we've measured that. So many years ago, we assembled a group of investigators from North America and Europe in which we tried to brainstorm on all of the symptoms of wearing off that there were about 15 of us had ever seen. And here are the motor symptoms. We decided that we would include a lot of different terms for slowness, a lot of different terms for stiffness, because patients in our experiences and maybe in our different languages had different ways of expressing these problems. And so we believe that this is a pretty representative array of motor symptoms in Parkinson's disease. We also spent much more time talking about non-motor symptoms of Parkinson's disease, and our experiences here were better informed by looking at other medications. For instance, abdominal discomfort and bladder emptying, is that up there? Bladder problems. We came to think about that in terms of treatments that we could use that patients who would use who were noticing problems emptying their bladder could give them an injection, and they would have an improvement in their symptoms and could empty their bladder. So a lot of these were just looking at different responses from different medications, but this is where we began to think about behavioral symptoms and other symptoms in Parkinson's disease. And actually, this is where I began to think about how dopamine agonists might produce impulse control disorders and that different type of thinking in behavioral symptoms of Parkinson's. So at that time, I had a database in which we could follow patients and we could recruit patients. And so we decided we wanted to look at these 32 symptoms and determine what of the symptoms, when we combined them all together, would capture symptoms of wearing off. So there were original 300 patients, and then we found 289 patients. And these 289 patients, when we looked at all of their symptoms combined, we found that these 19 would identify all 100% of the patients who had symptoms of wearing off, whether they had one symptom or whether they had one patient had 23 of the 32 symptoms, which would be a long evaluation if you didn't have the scale. The scale could allow them to check that off quickly. We decided that there were some redundancy in this questionnaire, And we also thought that it may have been too sensitive. So numbness was a symptom that many people could have, pain people could have, and it wouldn't necessarily mean that they had symptoms of Parkinson's or this is a wearing off symptoms of Parkinson's. So we assembled a group. It was a little bit different than the original group, and we began to beat up that scale to say, all right, how can we look at questions that would be more sensitive, be more specific for Parkinson's disease and just as sensitive? And so when we reduced our scale to 9, as you can tell, we combined, it's really 11 because we combined cloudy mind and slowness of thinking and anxiety and panic attacks into one symptom. We found that this questionnaire identified more than 90% of the patients in the original cohort. So by getting rid of 10 symptoms, we were able to still maintain a fairly representative sample of wearing off, and we thought that our specificity was somewhat better. Then we decided to test this in a group of clinicians, and we had the clinicians come through and they determined whether there was wearing off or not. And then we had this questionnaire, the 9-point question questionnaire, and we compared them. And you can see that there was a wide range of physician-reported wearing off from 14 to 70%, while the questionnaire was a little more consistent between 50 and 80%. I would tell you as a reviewer that Site 2 would really concern me, and if you're a young person getting ready to publish data, if your data look perfect, I'm really not going to believe your data. Data are not perfect in clinical research, and so, but with that caveat, I would say that we found a tighter range of symptoms of wearing off and a bit more consistency, not great, with the questionnaire as opposed to comparing highly experienced clinicians in Parkinson's disease. And as you can see here, that the sensitivity of the questionnaire was still quite high at 96%, but our specificity was quite low at 40%. And that's where I think we're looking at troublesome off or bothersome off. I think that the physicians were able to evaluate really was what was most bothersome to the patient, while the patient was being able to check off these symptoms without a really regard to whether they really bothered them or not. And so by not involving patients in this original scale, we were not really able to capture, I think, maybe the emotion or the intensity of these symptoms very well, and that's where I find a weakness of the scale. However, I think it is very good for screening patients if you're going to put them in a clinical trial, or screening patients if you're going to put them on a new therapy for treating wearing off, because it will allow you to be allow the patient to be highly sensitive in indicating the symptoms of wearing off, and then you can evaluate those symptoms to decide whether they're truly worth treating and make that decision of whether you're going to make an intervention. If you want to assess wearing off and whether you're having a response to medications or not, this is the way we have done this historically. We have a unified Parkinson's disease rating scale, and we measure patients when they are in their off state. We provide the medication, and then we measure them when they are on their on state, and we look at the difference, and that's how we can tell if there was an effective response to a medication. This is a force that's coming about with Kinesia Technology. There are a number of these companies, but Kinesia is the company that I think is, at least in the U.S., emerging as having a lot of influence in clinical trials. And to me, this is just a better UPDRS. Instead of asking a patient to tap their fingers, we're asking them to tap a button, and we're getting a better quantification of the motor ability. And this thing, the pedometry, I should have practiced that more. Toe tapping assessment is simply putting their foot in this assessment and seeing how well they can tap their foot. I would also think that would be a good way to assess their driving abilities, but that may be a difficult time and something for another lecture. We also use UPDRS Part 4 to query a patient about whether they're having off periods that are predictable, whether they're unpredictable, and how fast they can occur. Can they occur within seconds? And then we simply query them for how much of the day do you have wearing off, under 25%, between 25 and 50, 51 to 75%, or 76 to 100%. So again, this is not a very accurate way to assess the subtleties of wearing off. And if you're only on 12 hours, if you're only awake 12 hours a day and you're off 25% of that, that's one thing to consider. But if you're off 26% of that, it's another thing to consider whether that 26 to 50% rank is a big issue. So that's what led to Bob Hauser and others to determine a diary. And I agree with Joaquin that OFF is not properly assessed in this because we didn't think OFF at that time really mattered. The diary was actually developed during the context of looking at dyskinesias and trying to understand them better, while the wearing off questionnaire was really developed to look at understanding OFF better. And it may come time that we need to fill out these with additional categories. Again, this is now looking at Kinesia, and they have a home-based treatment that is connected, in this case, to a smartphone. And you can see that it's a watch that will connect to that smartphone. You can set this to query however often you want. So this shows from 12 to 12:30 a.m. and you can indicate that you're sleeping, I suppose, when you wake up. And then every 30 minutes during the day, you can indicate whether you're on or off. The watch, so there's a watch that goes around the wrist and another device that goes around an ankle. That also assesses whether you are going to have off symptoms or on. And so this is diagram at the top, the curved line represents tremor, or I guess off period, and the bar graph represents time of dyskinesia. So you can see that patients are taking their dose at around 8 a.m. or 7 a.m. and they are still having tremor. The tremor goes away. They develop this bar graph of dyskinesia. Then the tremor, then it goes away and the tremor returns. And then you look at a summary plot below, in which they are on the right, on your left, they have an assessment of severity of tremor and the number of hours per day that they've been awake. And on the right, dyskinesia and the severity of dyskinesia. So this is a very useful way to assess a diary in an electronic fashion at home, rather than, I think, relying on patients to remember every 30 minutes to determine where they are. And so, in summary, I'll remind you that we have evolving treatments and we need to evolve our assessment tools. And so the wearing off questionnaire was developed as we were beginning to think about wearing off, but we didn't really think about wearing off in terms of what a patient feels. It was just how a group of physician experts looked at wearing off. And in the future, I think it will be very important to have better diversity in that conversation. And I think it may result in obvious, in retrospect, redefining or remodeling of what wearing off and off periods would look like. I think the wearing off questionnaire 19 and 9 are both very useful in screening patients for wearing off, but they don't have a value attached to them. So you might have a little change in numbness in your hand when you're wearing off, and that doesn't bother you. But if you're unable to remember your grandchildren's names, that might be really bothersome to you. And so we need to figure out ways to better assess where that would lie. I think in our clinical practices, it's just conversation between a doctor and patient. But in clinical research, we may need to develop better definitions for this. We have not had very good tools for capturing the duration and severity of wearing off in the past in our questionnaires and our clinical assessments, but I do believe these electronic devices that are being developed and our iPhone technologies will allow us to do this better. And I think that these evolving technologies may help us better define when we're going to have major symptoms of wearing off and motor fluctuations that require an intervention or at least a decision to intervene, and whether they will not. So thank you for your time.
Thank you very much, Mark. And now I'm actually reviewing the challenge of treatment of, and then we have a panel discussion where you are kindly invited to participate. So first of all, thank you to all of you to be here, and to Sunovion to give us the opportunity to discuss this very important aspect of treatment of Parkinson's disease. You know, we're celebrating in these days the 200 years of Parkinson's disease, but still we are fighting since levodopa was introduced in the treatment of PD. We're fighting with fluctuations and dyskinesia. Definitely we achieve quite important results, but still there are problems and very clear problems. One of the main unmet need, as we discussed in the morning, is actually off period. It's a very common problem, affect almost all patients with Parkinson's disease, and actually it's a very important also the communication with the patient. I mean, I learned that sometimes we probably don't make ourselves clear. A couple of days ago, I was discussing with a patient who was clearly wearing off at a certain point at the time, and I said, "So this is your off time?" And he said, "No, I'm not off. I just slow down. I just feel fatigue." They have a different perception. They think that off is somebody that freeze down, it cannot move. They have a different perspective. We should actually try to communicate and make the communication simple. Just explain that off is a way to express when levodopa, when the treatment is actually going down and they don't feel well, motor and non-motor symptoms are, as Joaquin explained at the beginning. Definitely off time are not adequately controlled with currently available therapies, and represent the major source of disability for our patients. They are due off period, actually are a consequence of different aspects, has been already discussed, wearing off, delayed on, and other problems, and they can be represented by motor and non-motor symptoms. What we do, I mean, how we approach today a patient with different kind of off. I mean, of course, we discuss in general terms. We try to approach this patient with different drugs and different approaches, depending if the wearing off is the main problem, delayed on or non, early morning akinesia, so on. But at the moment, definitely the first approach is to modify the levodopa dose and delivery, changing the timing, changing the dose. The first approach is to reduce the interdose interval. So we increase the dose frequency of levodopa. Use control release preparation levodopa, even if the one we had so far are not really effective. We use catechol-methyl transferase inhibitor, intrajejunal infusion in the very advanced cases, monoamine oxidase B inhibitor, COMT inhibitor, dopamine agonist, the new mixed monoamine oxidase B and other aspects such as safinamide or DBS. I mentioned the slow release preparation of levodopa. Definitely IPX066, which is already available in the United States, is definitely much better than the preparation we had so far. Cinemet chronic release or Madopar chronic release. This drug showed to be efficacious in reducing off time and reducing the timing of levodopa dose during the day. Unfortunately, it's not available in Europe, but another compound is under development and is called accordion pill. Is under in phase 3 trial. We can use catechol-methyl transferase inhibitor. A number of trials showed us that adding entacapone or tolcapone to levodopa in patient with fluctuation, we can reduce off time. Tolcapone was definitely more efficacious than entacapone. Both drugs gave, in fact, an increase in area under the curve, and levodopa is more available in the plasma level when you add a catechol-methyl transferase inhibitor. We hope, and the clinical trials point on this, that opicapone, which is the new catechol-methyl transferase arriving on the market, is already available in Germany and UK at the moment. Opicapone showed in the clinical trials to be more efficacious than entacapone, and it's a once-a-day drug. The tolerability is good with a good profile in terms of side effects. It doesn't seem to induce diarrhea or urine discoloration. We hope that this compound will help us in controlling better fluctuations. What about monoamine oxidase B inhibitors, rasagiline, and of course the selegiline before, and then rasagiline, the second generation, showed to be efficacious, and in the Largo trial, rasagiline was as effective as entacapone in reducing off time. And we're talking about around 1 hour reducing in off time during the day. Dopamine agonist, we still use dopamine agonist in controlling patient with fluctuation. They remain a very efficacious compound, and as you can see from these different clinical trials, pramipexole prolonged release, ropinirole prolonged release, rodigorin patch, so all these prolonged release preparation of dopamine agonist, they showed to be efficacious in controlling off in patient with PD. There is in these clinical trials, dopamine agonists were added on to levodopa, and they gave quite a good improvement in reducing off time. You know the limitation of the use of dopamine agonists, and so we are nowadays using them more carefully, but remain efficacious drug for this kind of problems. Safinamide, I put safinamide apart from monoamine oxidase B inhibitor because actually EMA approved this compound in a different file. In fact, safinamide is a monoamine oxidase B inhibitor, reversible, but also has an effect on channel entry blocker and glutamate. So they represent a different pharmacological entity. Safinamide showed to be efficacious in increasing on time in patients with already treated with levodopa. And interestingly, the study was a double-blind control trial for 2 years, for 24 months. And as you can see from this slide, the effect, the efficacy was maintained in double-blind for 2 years. And you see very interestingly the loss of effect of the decrease in the placebo effect. Continuous delivery of dopamine or continuous delivery of drug. I already mentioned the slow release preparation of different dopamine agonists, the transdermal rodigorin, and also there was a trial with lisuride, another agonist which is not on the market. We can actually use apomorphine in a subcutaneous continuous infusion, levodopa intrajejunal infusion, jejunal infusion. Then we can use the surgery, DBS, pallidotomy, and then the experimental flat ear implants, GDNF, BDNF, and cell therapies. The double-blind control trial, which has been recently published, and with intrajejunal levodopa, showed, intraduodenal actually levodopa, showed that this kind of approach is superior to oral treatment in reducing off time and increasing on time. So today, ideally, this is the best way to give levodopa because it's a very constant, it's a continuous delivery of drug, of levodopa. But still, if you look at the results of this very successful trial, you can notice that despite there was a very clear improvement in reducing off time, still this patient that actually were enrolled having 7-8 hours off during the day, they remained with 3 or 4 hours off during the day. So despite we treating this kind of patient with a very with conceptually quite advanced method such as continuous levodopa infusion, still we have problem with OFF during the day. Probably because there are other factors that contribute to fluctuations that are more difficult to handle. And these are the peripheral contribution to fluctuations. Absorption, for example, is one of the main problems. And this is, and of course, for oral therapy, the main obstacle is represented by the gastric alteration in patients with Parkinson's disease, plus the swallowing problem, the esophagus, and so on. But the stomach seems to play a pivotal role. We know that in Parkinson's disease, even in the very early stage, there is a delay in gastric emptying. In the course of the disease, this delay in gastric emptying can get even worse. Unfortunately, with drugs, can actually make this problem even more severe. And also the food they eat. We had a meeting a couple of days ago with a nutritionist and a gastroenterologist trying to find out which was the best approach or the best meal to suggest to our patient. And actually, anything you say, there is a problem. So if you eat fruit, it's too acid. If you eat carbohydrates, delayed gastric emptying. Fatty meat, don't even mention. Fresh salad, terrible. So, I mean, it's very, very difficult, this kind of aspect and topic. At the end of the story, delayed gastric emptying remain a huge problem, and as you know, levodopa is not absorbed in the stomach, has to cross the stomach and get into the small intestine to be absorbed. So if the tablet remains stuck in the stomach, there is no effect. And it's very clear from this pharmacokinetic study we performed a year ago that levodopa is absorption and in consequence of gastric emptying is one of the main factor inducing what Joaquin explained you as a delayed on or no on phenomena. Delayed on in the morning, early morning akinesia. This is a wearing off in this patient. And now, look, taking drugs at 4 o'clock in the afternoon, no rise in plasma level until almost 7. This is a very clear delayed on, which it's about 3.5 hours. And so these patients spend all the afternoon off because of the lack of the efficacy of this drug, of this tablet. So that's remain an important aspect, and we see these problems with any kind of treatment and any kind of approach. So that's why rescue therapy for off episodes in Parkinson's disease is so important. It doesn't matter what the patient is taking. I mean, very recent, there are patients on DBS with very severe non-motor off during the day, for example. There are patients treated with infusion that they still have off during the day. So the rescue therapy is a therapy intended to provide a rapid, predictable treatment for all periods in significant unmet medical, and represents a significant unmet medical needs. Apomorphine is the drug which has been used so far. It's the only rescue therapy available at the moment. Apomorphine is a very potent dopamine agonist, having D1 and D2 effect. It's induce less psychosis and less dyskinesias than other compound. The onset of action is between 7.5 and 10-12 minutes post a subcutaneous injection. The maximum plasma concentration is reached between 10 and 20 minutes. The half-life is pretty short. It's about 43 minutes, and the effect of a single injection lasts between 50 and 90 minutes. So, so far, the only available rescue therapy is the one represented in this picture, is actually the pen inject with apomorphine. But now and in the next future, hopefully, there are other possible approach. One is represented by inhalating levodopa. This is a device that actually permit the patient to inhalate levodopa. Levodopa get into the lung and is quickly absorbed. As you can see here, actually the method of using this kind of device may be a problem in patient with PD. They have to prepare the device and then they have to be able to breathe deeply levodopa to reach the effect. But if the patient is able to do all of that, then you have a very fast and predictable peak through pulmonary absorption of levodopa. That's the oral, and that's the pulmonary absorption. And this is translated into quite a fast effect of this kind of approach, with a reduction in significant reduction in time to on and efficacy represented in UPDRS. Another possible approach is actually represented by, again, by the same drug, apomorphine, but in this case given sublingually. The APL 130 is a sublingual apomorphine strip. Is a very thin B-layer film that you can see in this picture, which is immediately dissolved when put it under the tongue. You will see here you have a strap, and the patient take this film, put under the tongue, has to keep the film under the tongue for at least 1 minute without swallowing, and this produce a very fast rise in apomorphine plasma level. I will see in a second. These are the different size of the strips according to the dose, and these are the plasma profile compared with the subcutaneous infusion. So you see the subcutaneous inject. Sorry. So this is the injection, different doses, of course, and this is the sublingual strip. So the peak of the sublingual is actually lower compared to the subcutaneous, but it reaches a significant level in the blood, and it lasts as there is not much difference between the subcutaneous and sublingual. The sublingual seems to be a little bit longer in terms of duration in plasma level. So a phase 2 trial has been performed with this sublingual strip and recently published in 2016. This slide represents the patient, the percentage of patients that turned on during this study, and you see the effect was, I mean, the number of patients who actually turned on with the sublingual strip was quite significant, almost close to 100%, and the effect, the effect size was measured by the UPDRS, and as you can see, the improvement in UPDRS was significant and definitely over 30%. So this kind of approach in this phase 2 trial gave quite encouraging results, and a phase 3 trial is now ongoing. Of course, we have 2 rescue therapies which will be hopefully available in the future. One is the CVT-301, the inhalating levodopa, and the other one is the sublingual apomorphine. In this slide, I just wanted to represent the characteristic of one and the other. One is a formulation levodopa, has to be inhalated. The dose goes between 35 and 50 minutes, but the long-term pulmonary effect is not known. On the other side, we had apomorphine. It is a formulation of apomorphine, is administered sublingually, does not require carbidopa, whereas the other one requires carbidopa because there is no carbidopa in the inhalating preparation. There is a possible agonist side effects. There are different doses again. The oral effect is unknown, and the onset versus subcutaneous is not still very clear in terms of difference. So this is was a very quick overview of what we have available at the moment. I think that the message is, first of all, that the off period is still a problem despite all the different therapeutic approach we actually apply. Still we have to work in searching and producing drugs for better treatment of PD. And despite all the different approach, rescue therapy, which actually make the life of our patient easily and more predictable, is actually something that is an unmet need and is definitely required. Thank you.